pleasure to introduce our webinar, the first one of our 2017 season, Beyond Projects and Programs, 5 Steps to Patient-Centered Culture Change. And as many of you know, the Patient-Centered Primary Care Collaborative focuses on person, family, and community engagement. We've updated our website, and we encourage all of you to visit the website to see our new resources and links around person and family engagement. And for those of you who have colleagues who missed the call, we will be recording this call, and you'll find that in our webinar section on the new website. So it's my pleasure to introduce our 2 presenters today. First, we have Susan Brown, who wears many hats. Among them, she is part of the TCPI faculty, and she's also a 25-year employee in the healthcare sector, where she has both the perspective of a patient and family caregiver and as a healthcare provider organization representative. She is the Health IT Director for Telegen in Des Moines, and she also has experience as Director of Iowa's Health IT Regional Exchange Center, which provided technical assistance to over 1,500 primary care practices and 84 critical access hospitals. She is also the parent and caregiver for 2 kids impacted by serious genetic disease, and she is the co-founder of a local nonprofit called Let's Soar Together, which advocates for special needs children within the school system and the community. We also have Sarah Guastello, who's Director of Knowledge Management for Plaintree, which is one of PCPCC's partner organizations in our Support and Alignment Network program. Sarah is an expert in person-centered care, drawing on research and observational fieldwork. She develops educational implementation resources that guide healthcare organizations to deliver patient and person-centered care. She is part of Connecticut's Advanced Medical Home Vanguard, which is part of a SIM grant, and as I mentioned, also part of PCPCC's Support and Alignment Network. So we're very pleased to have Sarah and Susan with us, and we look forward to their presentation on 5 steps to person-centered care. So Susan, can I turn it over to you?
Yes, thanks Liza, and thanks for the opportunity to be here. I consider it a real privilege to get to share about my family. So you can see a display picture of myself and my 3 kids, and how this all played out is my oldest son, Caleb, is 23. He was born just like a typical child, nothing wrong with his genetics, and then we had 2 more kids and found out that we did have a genetic syndrome in our family. And so Reese over to the left is 18, and Jessica to the right is 20. And so they both have what's called Fragile X syndrome, and it causes severe intellectual and developmental disability. And I'm going to talk mostly today about Reese. He is 18, as I mentioned, completely nonverbal. He's incontinent, and he has seizure disorder. And I want to tell you 2 stories about Reese's recent healthcare experience that I think shed light on my points today, which are listening to patients and finding a way to say yes. And so I stand for healthcare that responds to the needs of the patient and the family and the caregiver. And when persons with severe intellectual or developmental disabilities are involved, the care system needs to be flexible, and the care needs to be tailored to the patient and family situation. So in terms of my 2 stories, I'm going to start out with my success story, which is that last fall, Reese needed outpatient surgery, and this might sound simple, but in his life it isn't. The everyday normal is very stressful for him. And so he loves his routine. He hates deviation from his routine. And even literally getting him through the door from the car to a healthcare appointment can be very difficult. In fact, he's so much bigger than me now that I can't physically redirect him places, and he greatly resists transitions. So by the time we even get to an appointment, it's been a major ordeal. And so we went for his pre-op appointment for this outpatient surgery that he needed. And they had a wonderful office manager, and she talked with me about how they could make things go well for Reese. I mentioned to her that since we would have to get there at 5 in the morning, I simply asked that he not be restricted to an exam room, be forced to sit on a cold metal table with white paper. Could he just hang on to his iPad and wander around until they were ready for him? And if they needed vital signs, could they come to him instead of forcing him to come to them? And so she took notes on that. And then after I left, I started thinking, you know, while he's going to be under anesthesia, are there other healthcare needs that could be met since this is such a traumatic ordeal for him? While he's sedated, could we do other things? So I thought, they're going to think I'm crazy, and they're going to tell me no, but I'm going to go ahead and ask, could we, while he's sedated, have his dental hygienist come in and do a full cleaning without any resistance? And could they do x-rays? And could the phlebotomist come in and do the necessary blood draws for his neurologist? And could I take care of some grooming needs like haircut, which is very difficult for him, shaving, and cutting his nails? I completely expected to be rejected, but to my surprise, the surgeon has a relative with special needs and totally understood the situation and agreed to keep Reese under sedation while we could perform these additional tasks. So I lined everything up, the dental hygienist, my brother-in-law to cut his hair, the staff lined up the phlebotomist, and it was just, it felt like such a team approach. I felt so listened to. I felt so respected and honored that this group would actually make this happen. And so that's what happened on that day. We came into the appointment. They let him wander around. He went behind the desk. He went all over the place with his iPad. He was not stressed out. They let him take his iPad into the OR. Then we took it away from him, and we performed all of these different procedures. The surgery accomplished what it needed to. And you know, I felt encouraged and very supported that day as a caregiver. And there's so much of our lives that's difficult that it was refreshing to have that treatment within the healthcare system. So my vision is for teams of caregivers to come together like that, for patients to be listened to, or caregivers to be listened to as I was. I didn't expect the answer to be yes, but I felt listened to, and then when the answer was yes, it was an extra bonus. So that's story number one. And then story number two is not what I've considered to be a success story. And this is where I take the kids to a Center for Disabilities, which is 2.5 hours from our home. And this is a specialized center for excellence for their condition. And when we go there, I have to pull Reese out of school, which is his happy place. I have to take the day off work. Medicaid, because they're on a waiver program, pays for our mileage and our meals and the visit. And basically when we get there, because Reese can't tolerate even vital signs being taken for the most part, he basically sits on the floor at the Center for Disabilities, and it ends up being a couple-hour interview of me by several providers. And so it just feels to me like it's a waste of Medicaid money. It's a waste of my time. It's stressful for the kids. And they could accomplish the very same purpose, which is basically refilling his medications much more efficiently. And so I suggested at one visit, could we possibly maybe have him come here once a year, and then on the in-between visits, the quarterly visits, could we do a Skype visit or a FaceTime visit so that you can visually see him, but then proceed with the interviews with me? And I was immediately shut down. The response was, well, we've never done that. We don't do that. Our providers don't believe in that. And again, I didn't expect I don't expect all of the answers to my suggestions to be yes, but I felt, not listened to, not heard, just because of the immediate shutdown. And that discussion never went any further, so we're still doing this whole daily routine every quarter to make sure that my kids stay on the medications that they need. So those are just two different examples of listening to patients, finding a way to say yes, or not saying yes or listening at all. So those, I hope, illustrate at a practical level some of the points that Sarah is going to make in terms of becoming more patient-centered, person-centered in the care provided at your practice. Thank you. I'll turn it over to Sarah.
Thank you so much, Susan. It's always so powerful and fitting, I think, to start these types of educational events and webinars with a personal story. And that's because we can learn so much by listening to the stories of patients and family caregivers, both those stories of success, like that Susan shared, as well as those where it wasn't a success and it left a lot to be desired. But hearing those stories, the good, the bad, and the ugly can really be instrumental in unlocking solutions, because they help us, I think, to start to consider this work we do from a different perspective, when it's not about the tasks and the documentation and the data and the workflow, and it's really about the human beings that we're caring for and interacting with, and their lives and their well-being. Just taking, really looking at this work through that very deeply personal perspective. So for that reason, I think there's very few things that are more powerful than stories. But one thing that I think is sort of on par with that is sort of drawing on this Victor Hugo quote, an idea whose time has come. And that brings us to what I want to talk about, which is patient and family engagement, which I would argue is most definitely an idea whose time has come. Now, from Susan's stories, I think we can draw a couple of conclusions. One, that there are absolutely some pockets of excellence and real bright spots where patient and family engagement is making such a profound difference in the lives of individuals who interact with our healthcare system. But it also, her second story also suggests we have a ways to go. So I thought we should take a moment just to reflect a little bit on how far we have come. Oftentimes we're so focused on where we're going, we don't sort of reflect back. So just as a little bit of more introduction about me, as Liza shared, I am with an organization called Planetree, and Planetree is a patient-centered care, education, advocacy, and coaching organization, and we've actually been around for almost 40 years. And back 40 years ago, these ideas around patient and family engagement and the roles that patients and family members would play as members of their own care team were considered radical. They were definitely, this is a fringe notion, to be sure. But today, again, fueled by this idea whose time has come, Planetree works with more than 700 healthcare sites across the full continuum of care in 20 different countries. And as Liza said, we're also a partner with the PCPCC Support and Alignment Network, which is what brings me here today. And in all of this work, Planetree's emphasis is largely on how organizational cultures can be enhanced to really fortify patient-centered practice in action. So back to sort of how far we've come, this is what going mainstream looks like. Concepts related to patient and family engagement, as you all know, have been embedded into policy initiatives and research agendas and reimbursement models. And because of this, patient and family engagement is really on the radar screen, or perhaps sort of more to the point, it's in the strategic and operational plans of a critical mass of healthcare providers today. So the will to achieve a healthcare system that truly promotes and facilitates patient and family engagement is stronger than ever before, driven in part by initiatives like TCPI and CMS's PFE strategy, as well as work coming out of the National Academy of Medicine, tying patient and family engagement strategies to better care, better health outcomes, and lower costs. So when there's a will, we look for the way to really turn that will into action, right? And in this case, the TCPI change package really serves as that roadmap for implementation. But sometimes what can happen when you have a roadmap like this is you can get so focused on the specific coordinates or the tasks that you may sort of fall into the trap of losing sight of the bigger picture and how all of those discrete activities really work together to truly transform your practice. So this change package is very much an example of the whole equaling more than the sum of the individual parts. And that's what I want to emphasize for you today. So I thought that a good way to sort of level set this conversation, I went too far, is to just refresh everyone briefly on CMS's definition for patient and family engagement, which is that patients and families are partners in defining, designing, participating in, and assessing the care practices and systems that serve them to assure they are respectful of and responsive to individual preferences, needs, and values. This collaborative engagement allows the individual's values to guide all clinical decisions and drive genuine transformation in attitudes, behaviors, and practice. So there's a lot there, obviously, and you can certainly see how there's a lot of different activities and changes and processes and systems that are going to be necessary to achieve that vision of patient and family engagement. You're going to need structures in place to facilitate those partnerships with patients and families. You're going to need care processes and tools to really invite their participation in care, systems to understand and accommodate individual preferences and needs and values, just to name a few. But what I want to really focus in on are those last 8 or so words in red about driving genuine transformation in attitudes, behavior, and practice. Because this gets to the fact that all of this work is in service of not only adjusting what we do, so those practices, but also really looking at the beliefs and the mindsets and the attitudes around what we're doing, how we're doing it, and why we're doing it. And together, those practices and actions, along with those behaviors and attitudes, are what make up your practice culture. And it's that overlay of practices and actions with behaviors and attitudes that are going to drive those outcomes that we're seeking to drive, like improved health outcomes for patients, reduced readmissions, and lower costs. In fact, an article just came across my desk yesterday that was published this month, and it's a study that emphasizes just this, what I'm talking about. And the article concluded that having a primary care team that reports a patient or person-centered culture was associated with better health outcomes for patients. And so that's why we're focusing today on culture change. And when we talk about culture change, I know that can feel overwhelming and daunting, and you don't even know where to start. And I can also appreciate that there's a lot on all of your plates these days with 120-day plans, and you have new PFE metrics, and you've got documentation requirements, and the list goes on. I feel like if I continue with the list, it may cause agita among some of you. So I can imagine that for some of you, you may be thinking, on top of all that, now you're adding culture change to my to-do list. And that's really the first myth I want to bust here, which is that culture change isn't one more thing to do. Instead, it's really how you create cohesion between all those things you are doing by connecting them to this common why, or this shared sense of purpose that really grounds all of this work in a shared sense of a purpose and meaning for everyone involved. And finding that common why and tapping into it and grounding all this activity back to that why is what ultimately creates a culture of patient and family engagement. Because when you've cultivated that kind of culture, this spirit and intent around partnering with patients, trying to work with them to find a way to yes, as Susan said, and really listening and inviting patients and family members' participation, that's what's going to drive the most meaningful changes, not your list of to-dos. So having said that, I'll go back to what I just said about a minute ago. I know it can seem very daunting. So what I want to do over the next 20 minutes or so is hopefully break that concept of culture change down into more manageable sort of steps for you, So I'm going to break it down into 5 steps to patient-centered culture change. And then just back to that spirit of connecting the dots, I also will be sure to indicate where what I'm talking about really relates specifically back to some of those drivers in the TCPI change package. Because what I'm sharing today is not activity in addition to that change package. Instead, it's about sort of how you can do all that work in a thoughtful way, and in a way that all the activity builds on and connects with the other activity to really redefine how your practice operates. And it's not just what you do, but who you are as an organization. So let's get to those 5 steps of culture change. This is not rocket science, as you can see by these steps. In fact, the theory presented here is fairly basic in terms of the premise. But what I don't want to suggest is just because it's a basic set of theories that they're easy to do. Because the devil's in the details, right? In other words, the real challenge is how do we take these theories and connect them and convert them into practice and sort of practical applications that you can bring back to your offices with the aim of every patient every time. So that's really what I want to focus on, is moving from theory to practice with the recognition that none of these works in isolation. We're talking about culture here, and what creates a practice culture of patient and family engagement is when each of these elements is working in concert with the others. So we're just going to go through these steps one by one. Starting with ask patients. And this, of course, brings me back to where Susan started, and she said, what was really important and what she wanted to convey was the importance of listening to patients. And we can invite that conversation in when we first ask patients about their experiences and really engage patients and family members as our partners in this ongoing improvement and continuous learning effort. I mean, it's not uncommon in healthcare that we embark on this kind of work with the absolute best of intentions to make things better for patients and their loved ones. But oftentimes, we let our theories about what matters most to patients and our theories about what patients want guide those next steps. For an effort to be truly patient-centered, and if we want to create a strong foundation and underpinning for this culture, we need to involve patients and family members in more meaningful and purposeful ways to help us first, number one, to understand what are the right problems to be solved from their perspective. Second, help us to identify solutions that are going to best work for them and their family caregivers. And third, to help us understand if those changes and improvements that we've made are actually making a meaningful difference for the very people they're meant to benefit. So all of that really requires an honest dialogue and a receptivity to what patients and family members have to say, what they want, how they perceive their experience, and what they identify as gaps in care or in their experience. So to get there, we need to put in place channels like what you see here to really promote communication and to support that kind of dialogue. So just to briefly kind of walk through these, Eliza mentioned in her introduction of me that I'm involved in a project here in the state of Connecticut through a SIM grant around an advanced medical home. And through that work, I've spent a good deal of time over the last 2 years in primary care offices, basically embedding myself in these offices for a day, talking to patients and family members, doing sort of impromptu interviews, just asking patients and family members about their experiences with the office. Now, most of these offices were already doing some sort of a patient satisfaction or experience survey, but they still have found that these interviews were really helpful and were very insightful to better understand their patients' perspectives. And that's because they were getting this feedback in patients' own words, talking about the aspects of the experience that they really wanted to talk about instead of responding to specific questions. So that kind of feedback, and these were done in waiting rooms and in exam rooms, sometimes before a visit, sometimes after a visit, sort of a high flex process. But that type of information from patients can be so so invaluable to help you narrow in on changes that are going to be most meaningful for your particular office. And as well, and I think this is really important, in the midst of this kind of intensive period of activity that you all are involved in right now, having those conversations with patients can help you to make sure that as you're introducing new systems or tools or processes, you're also doing what you can to preserve those aspects of your practice and your office that may really be important to patients and may really drive their loyalty. So that as you're introducing changes, you are also, you're not doing so at the cost of sort of compromising some of those things that really mean a lot to your patients. So those one-time patient interviews could be expanded out with a focus group, maybe a group of 5 to 8 patients who you invite in over dinner or lunch on a quarterly basis, and just have a small group discussion, because oftentimes when you have other people sharing their stories, it may be really effective in unlocking an even deeper level of dialogue. So those are one-time opportunities to probe into those experiences and ask patients about what really matters, and gets you sort of a good sampling of patients. But they also may be a good opportunity to identify specific patients and family caregivers who could potentially be interested in being involved on a more regular basis beyond that one-time opportunity. And they could be recruited as patient and family advisors, or I personally prefer the word patient and family partners. And they could potentially meet on a regular basis as part of a patient and family advisory council or patient and family partnership council, as a group that your office reaches out to as needed to really weigh in on specific questions you're wrestling with and to have them help you guide your ongoing improvement efforts. And the fact that that group is involved continuously can really build their engagement level and create a greater comfort level with the office staff, so you just start to work together more effectively. So that's where we start. We start with asking patients. And then again, I'll connect it back to the TCPI drivers so you can see how this is all connected. And not for anything, when we do ask patients what matters most to them, we may be surprised by what we hear, right? I mean, if you ask yourself what you think would come up most as patients' top concerns about their healthcare experiences, particularly in the physician office, maybe you think what comes up most is things related to access issues, or like wait times or times to get an appointment, maybe costs or convenience. But what you see on screen are representative quotes from the patients I've interviewed over the last 2 years that really reflect the kinds of conversation I've been having with them. And you can see that what matters most is relationships and caring attitudes, feeling heard and respected, establishing trust and feeling like their care is personalized to them, that the care team gets to know them as a person. And I just wanted to bring this up briefly because, we spend a lot of resources and the energy to address what we think is going to create better healthcare experiences for patients and family caregivers. But if we're not addressing these issues, we're missing the boat. And we wouldn't know this if we didn't ask. So moving along to number 2, empower the care team. So here's the thing about patient-centered care. A practice can't be patient-centered if it's not also tending to the needs of the care team. The two can't be separated, and that's why we hear a lot about, and there's a lot of focus right now on joy in practice. It's really, really important. The care team, they're really your frontline ambassadors to patient-centered care. Policies and documentation and training and fields in your EHRs are only going to get you so far. It's ultimately the actions and the attitudes and the behaviors of those on the care team that are the bridge between an office's sort of philosophical commitment to patient-centered care or patient and family engagement and patients' actual experience of that commitment. So just like patients want to have a voice that matters in their care, staff needs to have a voice that matters in this ongoing quality improvement and continuous learning. So they really need to have the opportunity to participate in decisions that affect their functional work area or the specific role that they play on the care team. And that's what we mean by participatory quality improvement. So that means creating avenues for soliciting staff's ideas but also a feedback loop so that they are kept abreast of the progress on those ideas or projects they've been involved in. And that feedback loop may mean that it is communicated back to staff if an idea they had is just not a viable one. It's not going to happen for whatever reason. At least there's an opportunity for them to know it was heard and considered, and then they know that it's sort of gone through that vetting process and it's just not going to happen. So, by the way, this doesn't necessarily require setting up new systems to do this. You can leverage processes that are already in place, like huddles or staff meetings or staff lunches or communication boards or suggestion boxes or leadership rounds. There's a whole bunch of ways you can do it. But what's most important here is that intent of staff having an opportunity to influence how their work occurs, or to be able to have some avenues for communicating, what barriers that may keep them from doing their work efficiently, or what could help them to do their work even better. Providing staff support services is another way to empower or enable the care team to really provide the best possible patient care, because healthcare professionals can't give what they don't have, and it's unfair to expect them to. And so if they're feeling depleted, or they're really struggling or not feeling supported, it's unfair to expect them to then be a source of support and convey those caring attitudes. So what this means is they need to have space to decompress, to debrief after difficult experiences, some opportunities to balance work and life, and support in being healthy themselves. That's what we mean by care for the caregiver. And I've also included HR practices here, which includes reward and recognition practices that are tied back to attitudes and behaviors that relate to patient and family engagement. Again, this is how we're building a culture, how this is all sort of connected. It also includes orientation. So when new staff are being onboarded, how are they oriented to the fact that this is what your practice values? Hiring for fit, finding people, recognizing that many times the tasks can be taught and learned, but finding somebody who's going to fit within the culture is the more challenging piece. And then finally, also looking at performance evaluation practices. All of these are really touch points for not only reinforcing patient-centered care values, but also really formalizing them as expectations and competencies all staff are expected to exhibit. Tie that to the TCPI drivers. Of course, there's a whole section on workforce vitality and joy in work, and really empowering staff. So there's a lot of overlap here. So Susan's stories were really an example of real life example of number 3, which is engaging family caregivers. And that's because we know that a patient's healthcare experience extends well beyond the patient themselves. It often has a real ripple effect on the entire family unit, as I'm sure Susan can attest to. And that's why patient and family engagement needs to extend to family as well. I think we probably all know, based on our own personal and professional experiences, that there's an immense value that family members bring to the healthcare process and experience, because after all, they're the people who probably know the patient best, so they can help us to fill in blanks about the patient's health history, about their behaviors and patterns. They can also be really effective patient advocates. They're often the providers of hands-on care, and they're the people who are managing the patient's care in many cases outside of any sort of discrete healthcare episodes. So the first step, as you see here, to leveraging this value of family engagement is to first encourage their presence. So really breaking down those barriers that may keep them from being an extra set of eyes and ears for their loved ones, or that may curb our ability as healthcare professionals to have valuable face time for communication and education and support with those who are going to be supporting the patient in getting and staying well. So I wanted to share this study with you. When patients are accompanied into visits, they have better information recall and are more satisfied with the visit. So encouraging, actively encouraging, not just allowing, but actively encouraging patients to have someone accompany them to their visits and making sure there's adequate seating and space for the family in the exam room, and that they're not just sort of lurking in the corner, but they're really invited into the conversation, can be really instrumental in kickstarting the kind of engagement we're talking about here. But of course, to really maximize family engagement, we have to go beyond just enabling their presence to really encouraging their active involvement in care planning and goal setting and care management. And of course, all of this is in accordance with the patient's preferences. And I should also note, when I use the term family, I'm using it in the broadest possible sense. So family as defined by the patient. So who is the patient's sort of social support network? Who are their loved ones? So it's a very broad term. So the reality is, whether we support family engagement or not, these family members are very likely assuming the caregiving role for their loved ones. So a care partner program is really about taking full advantage of when family members are in our presence, doing what we can to build their confidence and competence so that they are best positioned to really help the patient in managing their care. So that's what a care partner program is. And then recognizing that it's important to also develop specific strategies and tools for the family caregiver, as opposed to just providing them the same information that we would provide to the patient, but things like tools that are specifically developed for family members, such as information on who to call with concerns, or some sort of a tracking tool for the care partner to use to track changes in the patient's health status that's provided to them as the family caregiver as part of their role on the care team. There we go. And that brings us to activating patients. So we started, number one, with asking patients. But there's a really big difference between asking patients what matters most to them and then truly activating them to take a more active role in their health and healthcare. Activated patients are, as the term implies, active participants on the care team. And there are specific techniques and tools, and I've just named a few of them here, that we can use to support patients in beginning to take the reins of their own health care. But we have to recognize that there's a pretty wide engagement continuum. So by that I mean that patients can have varying expectations and preferences for their levels of involvement and their levels of activation in their health care. Not every patient is going to be ready to independently complete a decision aid and come to a healthcare appointment prepared for a shared decision-making conversation. But those same patients could potentially be very receptive to a medical assistant asking them to share the top concern they want to be sure is covered during that visit, so that sort of to guard against them leaving with all the doctor's chief concerns covered but none of their own having been discussed. So I just put up 3 sort of examples of different ways to activate patients at different points of the engagement spectrum. And with each of them, going back to number 1 and looking at how all these steps build on each other, there are opportunities to roll these out and test them with patients to see, are the tools we are developing, are the processes we are developing, are they effective? Are they meeting the needs that you've identified? Help us to adjust this so that it is most effective for you, and it feels comfortable for you. It feels comfortable with the care team who's rolling it out. That's what co-design and co-creation is all about. So I started with teach back. So that's an approach I think many of you are very familiar with, asking patients to repeat what they've heard in their own words. So it may sound something like the member of the care team saying, let me be sure I've done my job and explained everything clearly. Could you share in your own words your understanding of what I've just said? And obviously here the goal here is to guard against patients leaving the office having said, yes, I understand, or no, I have no questions, but they're not having been that opportunity to really vet the fact that the way that information has been conveyed in a way that they understand. Collaborative goal setting is the process where the patient and the care team will jointly arrive at mutually agreed upon areas for treatment or change that address patients' preferences and priorities, as well as, of course, the care team's clinical concerns. That's the collaboration, right? It's both parties sharing what they identify as the primary concern, and having both sort of perspectives inform that conversation and the goal setting. And then we get to shared decision making, and this obviously could be a webinar in and of itself, which could last well over an hour. So I'll just speak to it really, really briefly. And I think that shared decision making in many ways is a natural byproduct when you have a practice that really listens to the voices of patients and family caregivers and activates them as members of their own care team. And it's the process of interacting with patients who wish, so there's an option here, in helping them to arrive at an informed, values-based choice among two or more reasonable alternatives. So that's sort of the formal definition. But what that entails is first identifying what those options are for the patient, and then collaboratively reviewing the risks and benefits and the pros and cons, and considering how those risks and benefits, pros and cons, align with what the patient has identified as what's most important to them. And then together, the patient and family caregiver unit and then the care team arriving at the right decision for that particular patient. What it's not is, here's my recommendation, how does that sound, right? It is a more intentional process than that. And I know that intentional process could sound fairly arduous and maybe more to the point, like it's going to take a lot of time. And that's why I think it's really useful to implement specific tools and processes to build that level of collaboration and partnership into the visit. And so starting with collaborative agenda and goal setting can be a way to sort of tee that up. So then you can build that out with tools like decision aids that'll provide more structure to the conversation. So that not only helps shared decision-making conversations to happen more reliably, but also more efficiently, which is, of course, really important. And just tying that to the TCPI drivers around respecting values and preferences, collaborating with patients and families, and, of course, being aware of language and culture and how language and culture may inhibit clear communication. And so that's why processes like TeachBack can be so important. And finally, we get to number 5, and then we'll open it up to some questions. And the final step here is to truly design your practice around the patient. And I think Susan's examples were perfect ones to sort of demonstrate how this can happen in real life when you get to know patients' preferences and their individual circumstances and how you may work together as a care team to really meet their individualized needs. So we start with team-based care, and I think I won't say too much more about that, just to, in the interest of time, and because Susan spoke so beautifully about that in terms of her experience with her son. But another key aspect of designing your organization around the patient is to ensure that amidst all of these tasks each of you has to complete every day. And there's really no way to get around that. I mean, I said that building a culture is around helping to connect the dots between all of these activities and tasks and connect them to that common why. I never suggested that the tasks would go away. But amidst all of those tasks, to find ways for every member of the team to reconnect to that greater sense of purpose and to really replenish their reserves to experience joy in practice. And so there are different ways that this can be achieved through sort of experiential education, through storytelling, by incorporating into existing processes and structures like huddles or team meetings, some sharing around why individuals chose a career in healthcare in the first place, reflecting on the profound impact somebody may have made on somebody's day or their week or even their life. Making sure that the team has opportunities to walk in your patient's shoes. So we recommend having members of the care team sit in the exam room or lay on the table and sort of see what patients see. Feel what it feels like to wait in there. What would you do if you were waiting in there for 10 minutes or 20 minutes? But really sort of put that patient hat on. And just recall what it's like to navigate through the healthcare system when you're not nearly as familiar with it as those of us who work in it every single day. So Plaintree has developed sort of a series of bite-sized exercises that do these types of things, reconnect teams to that greater sense of purpose and resensitizing you to the patient and family caregiver experience and sort of guiding you and examining the practice through the eyes of your patients. But there's also different YouTube video clips and things like that that can kind of just spur that kind of dialogue. And then finally, another way to design your practice around the patient is to literally design your practice around the patient, right? To really look at the physical environment and how it either facilitates or detracts from patient and family engagement. So if you want to encourage families' presence during visits, is there adequate seating for them in exam rooms? If you want to encourage patients to read up on patient education topics, how do you present those patient education materials? How do you set up your exam rooms with your EMRs to ensure that you're not compromising human interactions? Those human interactions that came through in those patient interviews as being so important. You don't want to compromise those in the interest of getting everything into the EHR. There's got to be a way to balance that, right? So bringing in patients as your partners to do things like patient walkarounds could be so helpful to help you identify opportunities to create a more healing and patient-centered practice environment. And because they bring not only that patient perspective, but also just a fresh set of eyes. They haven't been coming in, they haven't been seeing the same thing that you've been seeing day in and day out when you are there. There is such a thing as sort of home blindness. You sort of lose the ability to tease out some of those elements, and bringing in patients and family members can really help to illuminate opportunities that you may never have thought of. So like I said, culture change is really about how all of these different elements work together. These 5 steps are really your 5 building blocks, but I also consider them sort of the 5 critical competencies as you embark on this work. And I would just encourage you, as you continue to make progress here, first that you celebrate your progress. That's really important for building a culture as well, but also sort of look at how what you're doing ties back into these 5 steps and how you may continue to raise the bar as it comes to asking patients and empowering the care team and engaging family caregivers and activating your patients and really truly designing your practice around the patient. And so with that, I am happy to answer any questions that anyone may have.
Sarah and Susan, thank you both so much for that very helpful information about changing culture. And we encourage all the participants to ask questions in the chat box. People are still muted, but if you ask questions, we'll try to read them off and get them to our presenters. And for those that we don't get to on this session, we'll try to follow up with you afterwards. And I thought I would kick it off by asking Susan, you're an activated caregiver, and you're obviously very engaged in all of the care that your family members get. If the Medicaid clinic you were working with had done some of these cultural change steps, how could that encounter have gone differently, even if you got the same answer that they needed to see you for Medicaid regulations or whatever the outcome was? How could they have handled that better to empower you as a caregiver?
Yeah, I think it all had to do with their response to me, their openness to the idea. So for example, if they would have said even something as simple as, oh, well, we've never thought about that before. That's a really great idea, or that makes a lot of sense. We're not able to do it under our current infrastructure, but it makes a lot of sense. And I think the notion is viewing the caregiver or the patient as someone who's on your side, who's on your team. I mean, we as caregivers don't want inefficiencies just as much as you do. And we as caregivers don't want to waste your time. We don't want to incur unnecessary expenses. We don't want the visits to be unpleasant for you, just as much as they might be for, say, a difficult patient. So I think imparting the notion that, yes, we see that you're on our team. Yes, we hear your ideas. Yes, we appreciate your ideas. We're just not able to accommodate that under our current infrastructure, and this is why. That is a way different culture than we've never done it that way before. We just don't do that, or our providers don't do that.
And do you think it needs to be formalized in any way, like through a patient advisory council or through some kind of tools, or do you think that it just needs to be a process or an informal change of empathy?
Well, I think both. I mean, I'm a big fan of advisory councils. I personally would be thrilled to be asked to be part of a short-term, say, patient or caregiver feedback group, because that to me shows, we want your opinion, we respect your opinion. So I'm a big fan of that, but I think it has to go beyond that, because not everyone is going to be able to be engaged in something like that forum. So it has to spread to just more of the informal idea generation, responsiveness, even asking the caregiver or the patient during a visit, what's a good day like for you, and how could we replicate that, here in the office? So I think it's both.
Mm-hmm. Thank you. And Sarah, it sounded like one of the messages you really wanted to convey is that culture change is about putting all the pieces together into one unit around patient and family engagement. How would you explain that to staff and clinicians in practices that are in the process of transformation? What is the nugget of language you use to explain that culture change is not another box to check?
So the way I generally describe it is it's not what you do, it's looking at why you're doing it, how you're doing it. And when you start to, culture change also recognizes, there's ebbs and flows in culture change. And the reality is it's an ongoing process. It needs to be cultivated, but then continually kind of nourished. And that's where those bite-sized exercises for staff or other ways to really connect staff into that work is so important, as well as bringing in patients and family members as our partners. And I think, the way that I described step one, asking patients, I started with a fairly low-risk approach of doing some impromptu patient interviews, and then you raise the bar a little bit and you say, okay, now we're going to do something a little bit more formal and have focus groups and have a discussion with a group of patients, working toward identifying some patient and family partners who we will be able to access on a more regular basis. And what we're looking at is this increasing degree of co-design, but you don't need to jump in all at once. Right? This is a gradual process, and that's okay, because we're learning new skills, we're building new competencies, we're changing business as usual. And so what we're most concerned about when we're talking about culture change is the long-term sustainability. And so we need to find ways to really pace that work and introduce these changes in a way that gives us the opportunity to learn from them and adjust so that the next time we do something or the next time we're engaging patients and family members as our partners, it's going to be even more effective and potentially even more efficient. And so the main nugget around culture change is that piece around, again, we're focused on sustainability. So it's about doing, but learning from what you're doing and then adjusting so that the next time you're seeing better results and better results. And sometimes you're going to have what we call spectacular failures. And so long as you're learning from those, that's part of the culture change as well.
Mm-hmm. Thank you. And we have about 2 more minutes, so I thought maybe we'd close up by bringing it back around to the Transforming Clinical Practice Initiative. And I wonder if each of you could take a minute just to say how you think culture change relates to the person and family engagement measures that TCPI is adopting around e-tools, shared decision-making, patient activation, literacy, medication management, and patient advisory groups. How do those relate to changing the culture?
Yeah, this is Susan. So I think without a base culture where patients and caregivers are viewed as being part of the team and valuable members of the team, I think without that base culture, the metrics become more of a checkbox. So, you know, do we have a patient portal? Yes, check the box. We've met the metric. I don't think that that's the spirit or the intent of CMS incorporating the PFE metrics. I think it all starts with the culture, the mindset, and then that's what makes the metrics actually come alive and become meaningful, because then you start to look at, okay, not only do we have a portal, but how does that help us improve patient outcomes and improve the care experience? So culture is the base, and then I view that as the necessary foundation for making the measures actually meaningful and come alive at the practice level.
I don't know what I can add to what Susan just so eloquently stated. So maybe I'll just say it in a slightly different way, because she and I are exactly on the same page. The metrics can be really helpful for helping you to gauge sort of your progress, but if there's not that cultural underpinning, the cultural underpinning is what creates and really positions you for the long-term sustainability of this effort. And just to use the example of the patient portal or the shared or the governance metric, it's one thing to have a patient portal. It's one thing to have a patient and family advisory council. It's another thing to have a patient portal that's really driving outcomes and that is meeting the needs of patients and families. And we can't create that if we aren't first asking patients about their experiences with the portal and what they would be using it for, and talking to care teams as well about how are we going to integrate information into the portal, and how are we going to work with patients for using that information around patient education and bringing that back into the visit. All of that takes a culture that really values the role that patients and families play as members of the care team. And similarly, with a patient and family advisory council, it's one thing to check the box and have a group of people who get together on a monthly basis. But if you really, truly want to engage them in improving the practice in a way that's going to drive outcomes, it can't be a token group. This needs to be a group that has some ownership, whose voice carries some weight. Doesn't mean every idea that comes through the Patient and Family Advisory Council is going to be implemented. I'm not suggesting that at all. But there's a level of partnership and transparency there that is created by and really nurtured by this culture of patient and family engagement.
Great. So on behalf of the PCPCC Support and Alignment Network, Sarah and Susan, thank you so much for joining us today. We really appreciate this discussion of culture change. It's all part of the package of engaging patients and families in improving healthcare outcomes. We appreciate your insights, and for those of you who did not get your chat questions answered, we will try to respond to them via email. And thanks all of you for joining us. We will adjourn now. Bye-bye.